I'm fortunate enough this morning to also have a co-host, Mr. Doug Pyle, who's our Vice President of International Affairs at ASCO. And our best good friend will be moderating today, Mr. Alvaro Regado, who is the Executive Director of the ECHO Foundation in Madrid, Spain. Alvaro, welcome, and please introduce our speakers today.
Talk about the transition back to standard operations in cancer care after the pandemic shutdown. Each of them will have 10 minutes for the presentation, and once all of them are completed, we will have a 15-minute Q&A session. I will remind to encourage our audience to send their questions and comments through the WebEx application so we can proceed with the Q&A at the end of the session. I will go straight ahead and present our first speaker. Her name is Dr. Lori Pierce. She is the ASCO President-elect and also Director of Radiation Oncology at the University of Michigan. Welcome, Dr. Pierce, and please go ahead.
Thank you, Dr. Regado. So I was asked to talk about radiation services as the pandemic begins to wind down. May I have my first slide? So I've entitled this Radiation Oncology Practices as COVID-19 Wanes, Transitioning to the New Normal. So I thought before we talk about the ramping up of activity, we really should appreciate the ramping down. So when the pandemic first hit. And there were papers that were published across the globe looking at basic principles. And if I had to summarize the key points, they would be the following. First of all, important to provide a safe treatment environment for patients and for those in the clinic. And we also needed to triage patients according to the indications for treatment so that those patients who are at a very high risk of local regional recurrence would receive radiotherapy so there'd be no detrimental effect with regard to survival. And also patients with symptomatic metastatic disease where palliation was not adequate with medications alone. Those patients were clearly patients who required radiotherapy. But for patients who could safely have their treatment deferred, we did so for 1 to 2 months, and in some cases up to 3 months, depending upon the course of the pandemic. Clearly, we emphasized that for those diseases that we could use shortened fractionation schedules, if they were clinically validated, that would be very important to do so. And when possible, when we could deliver a treatment course very safely with simple plans, we did so as well so that we would minimize the amount of work needed and staff needed to do to have the more complicated plans. We went simple when it was possible to do so. Next slide, please. So then the ramping down when the pandemic hit of clinical activity in radiation oncology practices included triaging those patients who needed to have immediate treatment, coordinating patient management with surgery and medical oncology. Very important to do that so that the treatment plans that we presented to patients were plans that were coordinated from all of the caregivers. We created care teams so that we had attending physicians, residents, and advanced practice providers in-house on staff every day, and that way we could also have significant providers to be home working remotely. We schedule shifts for our radiation therapist coverage, and the radiation therapists are actually the people who push the buttons on the machine. And we had to make sure that we had adequate coverage from radiation therapists because most of our radiation therapists are in the childbearing age, and so they had young children. And so we, of course, had to make sure that they could provide adequate child care in their homes, and we had to make sure that we had adequate coverage in our clinic. We created physics and dosimetry workflows on-site and remotely, and this was relatively seamless. We realized that there were clearly ways that we could continue to have the work, whether patients were on-site or at home. And so we had to make sure that everyone had computers at home and they had the software that they needed to do all of the calculations. And of course, we did PPE training, infectious precautions and cleaning protocols. We initiated those. and we created physical distancing throughout the department. Next slide. And we, in many places, initiated virtual encounters, telehealth. Now, in many other places in the world, you were probably using telehealth encounters pretty extensively, but not in the United States. And so we initiated that, and that was a very important part of the way we delivered care. We also determined the appropriate protocol and workflow for COVID-19 positive patients. And for those patients who were enrolled in clinical research that were trials that did not offer a therapeutic benefit, such as imaging trials, all of those research trials stopped. So first and foremost, during the ramping down period, communication and coordination was absolutely essential. Next slide, please. So as we look toward the ramp up, it may not be as difficult as anticipated because radiation oncology, we never fully ramped down. We had work going, even though the numbers of patients were much less, we continued to work even during the height of the pandemic. Next slide. So will we experience a surge? Probably not. Certainly we'll have more patients to come back to radiation oncology, but I don't think it'll be a surge. So while we had a very rapid ramp down, we anticipate a more gradual return. Next slide. Now in the slide, you see that radiation oncology, radiation treatment's in the middle, and all the arrows are pointing toward radiation, which would suggest that we would have a surge of patients. But I think we need to remember that radiation oncology is not the entry point for most cancer care. Clearly, given the scenario of the pandemic, we had patients who were triaged to wait for their radiation to be paused, and we are bringing those patients back in now. So the triage radiation patients, they are coming in now. Medical oncology, as you'll hear from my colleagues, ramp down but never completely stop. But as they ramp up, we will get more patients from medical oncology. But without a doubt, the area that ramped down the most was surgery. We essentially had almost no surgeries for cancer patients during the course of the highest point of the pandemic, because many of the areas that we actually do surgery in, the operating rooms, were actually being used to care for our COVID-19 patients. So as that ramps up, we will definitely see more patients. Certainly radiology screening, that stopped abruptly during the pandemic, that is coming on board. So I think we will see a phased return. And if there are delays in any of these areas, we'll see further delays in radiation referrals. So I think it'll be more of a phase. Next slide, please. So then when we look at the ramping up of activity for radiation practices, first, we will schedule starts for those patients who were previously triaged to pause treatment. We absolutely will reassure patients experiencing anxiety. Some patients may not want to come back into the hospital, even as an outpatient, for their radiation. So we will need to encourage and reassure patients that precautions are in place, that they will have a safe environment to be treated. I've already talked about there will be transitions in radiology that will be coming on board with screening, pathology, surgery for sure, and medical oncology practices. We will increase our radiation oncology patients on treatment. And we will absolutely maintain virtual encounters, and I suspect we will increase them. Actually, just this morning in the New York Times, there was an article on telehealth about how important that is, and it's now, I think, here to stay in practices in the United States. We will maintain a balance, I think it's a healthy balance, between the workers who are on-site and remote, because we clearly have meaningful work that can be done from our remote workforce. We'll determine the optimal staffing for treatment delivery for our radiation therapists. We'll make sure that as the patients increase, we have the coverage to treat them appropriately. And while I mentioned before, as we ramped down, we were going more to simple plans, perhaps not doing intensely modulated radiotherapy, perhaps not doing respiratory gating, those kinds of things, we will begin to increase once again our complex treatment planning and delivery. We'll determine the optimum clinic schedule. As the patients increase, we will need to increase the number of hours that we're open. So I suspect we'll have extended hours, and we may be open every day. We will maintain the team model. because I think, as I said before, we clearly have very worthwhile work that can be done remotely. And we'll further refine the treatment protocols for our COVID-19 positive patients so we can further minimize staff exposure. And we will re-engage patients in clinical research. So for those patients who need to come in, we will certainly enforce physical distancing. And for those who can be seen virtually, we will do so. So once again, communication coordination will be essential to being successful with these ramp-up activities. Next slide, please. So we need to reflect upon the lessons learned and look at the opportunities for greater efficiencies, both in the Radiation Oncology Department and the institution in general. And I think a part of that will be looking at the optimum platform for the use of virtual technologies. Again, it'll be to determine the optimal balance of your on-site workforce versus those who can work remotely. And we will be very clear in delineating the remote responsibilities for our staff. Now, I've listed here on this slide all of the various workers in radiation oncology. We're very diverse. And you can probably imagine many of the jobs that they will be doing remotely. But I want to just bring your attention to radiation therapists. Again, these are the people who actually push the buttons on the machine. And so you may ask, how could they offer anything meaningful in a remote form? Well, I'll share this with you. In radiation oncology, we see patients for consult, and then usually a few days later, we'll see them to start. A few days later, they will start their treatment. It will be the simulation, then they'll start their treatment, and then they're on treatment for 3 to 6 weeks. At any point in time, they could get COVID-19. So just because you see a healthy patient at time of consult doesn't mean they will be healthy for the duration. And so it's very important to have frequent interactions, calls to these patients to make sure you go through the symptoms, they have not developed COVID-19, and they remain healthy. And that's something that the radiation therapist can do. They can call the patients throughout, reinforce the importance of physical distancing and reinforcing the actions to keep people healthy. We need to determine the optimal clinic hours to manage the department of the institution and make sure patient volume is appropriate. And we want to optimize our financial health. And we also want to reassess the improved models for conducting research. We can learn something from COVID-19 and be even smarter at what we do. Last slide, please. So COVID-19 is a complicated disease, and there are so many considerations. And I truly hope COVID-19 is waning. Here I am in the United States, and we have literally more cases than any place on the planet, almost 1.4 million cases and over 80,000 deaths. So I certainly hope that it is waning, and it appears certainly the state that I'm in that it is waning. And I hope that we will continue physical distancing and all of the efforts that we need to do to maintain continued waning of the disease. And I hope that in the end, we will emerge as a stronger health system, we'll emerge as a stronger discipline in radiation oncology, and we'll continue to be able to offer the excellent care that we've done through the years while maintaining safety for our patients and maintaining safety for our staff. Thank you.
Thank you, Dr. for your great presentation and for sharing with us your experience and knowledge. I would like to remind you to send the questions and comments through the WebEx app so we can address all the questions at the end. And now it's time to move ahead and introduce our second speaker, Dr. Jean-Charles Soria. He is the Managing Director of the Gustave Roussy Institute from France, a very well-known and recognized cancer institution in Europe and around the world. Welcome, Dr. Soria. Thank you for accepting our invitation, and now is your time.
Thank you very much, Dr. Rogado. I would like to thank ASCO for the opportunity to share the Gustave Roussy French experience on dealing with COVID-19. If I can have the next slide. So this is a graph that shows how the epidemic did hit the Paris region. We picked at 12,000 patients. That's the line in gray, and then in red you have the line of the patients that need to be hospitalized. And you can see Gustave Roussy, which is the dotted line, follow the same trajectory. And that was surprising because in theory, cancer centers were supposed to be shielded from COVID. But the reality is that the tsunami wave was so important that COVID patients arrived even in cancer centers, sometimes with cancer, sometimes just COVID patients without cancer. If we can move to the next slide. So this is the chronology of the key features on how we dealt with the crisis. I think there is one fundamental decision we took very early on, almost a week before France went to lockdown, which was to impose masks for all to anyone entering the premises of our hospital or research building, whether it was a patient, an employee, whatever the nature of the employee. And as you can see, there was a ramp up of our ICU beds that were occupied at the maximum only by COVID patients and the number of beds that we occupied. If we can move to the next slide. This is the prevalence on the left side of the slide of the patients, cancer patients. I'm focusing here only on cancer patients that develop COVID, and it's an 11% percentage of such patients. By imposing the mask for all strategy, the final prevalence of SARS-CoV-2 among healthcare workers in Gustave Roussy was only 4%, one of the lowest in the Paris area, where there are other hospitals who got contamination of the healthcare workers going up to 20%. Next slide. So here is how we adapted our therapeutic management of COVID-19 patients. And I, along with the other speakers, it's clear to say that we are all in a lack of strong randomized clinical trials, and that the priority should be to enroll within clinical trials. But then there is a pragmatic decision, which is what do you do once you have patients arriving at the door of the hospital? And as you can see, this is showing how we approach the issue. And one of the elements that we believe was important in improving the outcome of patients was the use of anti-IL-6 receptors and the use of steroids, which initially were controversial, but in our hands, in patients with important inflammation, using anti-cytokines or using steroids was important. Next slide. This is the analysis we performed in the first patients that were treated at Gustave Roussy with COVID and cancer. That's a total of 137 patients. And in multivariate analysis, when asking which patients do worst, what came out as an information was if they have hematological malignancies, they do worse than if they have solid tumors. If they have a poor performance status, they do worse. And then if we move to the next slide, the other element that appeared to be related with the worst outcome of COVID was if they had a chemotherapy over the last 3 months. We didn't find an increased or bad prognosis in cancer patients who were treated by targeted agents or in patients who were treated with immune checkpoint inhibitors. That was in contrast with chemotherapy as shown in this slide. If we can move to the next slide. So this is a capture of how the COVID epidemic led to a very significant decrease of our activity. On the left side, you have the drop of inpatient hospitalizations. Red is the 2020 data sets, and in black and gray, you have the 2018 and 19 data sets. And as you can see, this is per week. We had a drop that went up to 32%. The outpatient clinics was also hit very, very hard. We're starting to recover, but we went down up to minus 52%, and slowly we're ramping up back to more normal numbers. If we move to the next slide, surgery was also affected substantially. As in other hospitals, we had to close some of our operating rooms to use the ventilators for the ICUs, but we always kept a certain level of operating rooms open. But despite that, as you see, we almost had a drop of 50% of our surgical activity. Radiotherapy was also hit with a minus 38% decrease on the overall radiotherapy at the institutional level. Next slide. In terms of how do you handle care and how do you prioritize therapies, both for systemic therapies, radiotherapy, and surgery, Gustave Roussy, which is part of a consortium of comprehensive cancer centers in Europe called Cancer Core Europe, has published, in collaboration with those centers, a position paper in Nature Medicine that is entitled Caring for Patients with Cancer in the COVID-19 Era, and has very specific guidelines that may be of interest. Of course, it has limitations. We wrote this as the crisis was rolling out, but we tried to put together the brain of 7 different institutions. In the next slide, and this is my last slide, I would like to reflect a little bit on what happened during the COVID crisis that made the administration act differently. And there were some very positive changes that were induced by the crisis, correct? And some lessons that I think are very, very important when you are the management of a hospital. You need to make visible to the institution and the different members of personnel what the management sees. That means you need to have a data-driven communication that will allow you to decrease the emotional load in people. We are data-driven in our decisions, and you have to share that with the personnel. Communicating on key decisions and what was the rationale behind is also something very important. We need to maintain an engaged, transparent, and rational communication. The crisis led to a simplification of the decision processes, decreased timelines, decreased rigidity, increased interaction between the different stakeholders. And I think that brings an important reflection on we need to keep interrogating the rationale for established rules in the hospitals. What's the real cost-benefit ratio of the rules that we apply? In the setting of a crisis, of course, we had a central command that defined key strategic lines and philosophical principles, but then fully delegated their implementation to subgroups and field forces. And I think this empowerment of field teams was very, very important. Increased flexibility, generosity, and unlocked imagination with a problem-solving attitude at all levels was a characteristic of the crisis of COVID in our cancer center. And more stronger shared decisions between administration and healthcare professionals were important. Of course, the challenges in the future are not only financial, they're also about reassuring the patient, attracting the patient, allowing the patient to perceive that the risk of COVID is not higher than the risk of their cancer progressing. And I think that is not as easy as it is to be said, and is not as obvious. Dealing also now with more severe cases is a reality. We have many cancer patients with more advanced cancer that are arriving in the emergency room, and we need to keep an efficient telemedicine. So once again, thank you for the opportunity to share our perspective.
Thank you, Dr. Soria. Congratulations for your great talk, which I'm sure will be of a great help for all the attendees. Just as a reminder, please send your questions and comments through the web application so we can address all of them at the end of the session. And now, last but not least, I would like to introduce Dr. Stephen Chan. He is an associate clinical professor of the Department of Clinical Oncology from the Chinese University of Hong Kong. He will be sharing with us his best practices from the other side of the globe. Welcome, Dr. Chan, and thank you very much for being here with us.
Thank you, Dr. Rogado, for the kind introduction. I would also like to thank the ASCO for inviting me to share our experiences on resumption of the clinical services for our cancer patients after the COVID-19 pandemic. Next slide, please. So in the next 10 minutes, I shall walk you through the following areas: a very brief background about the situation of COVID-19 in Hong Kong, and I will also share the experiences and the challenges we encountered during the resumption of the clinical services for our patients. And finally, I'll give a concluding remark. Next slide, please. As most of you could still remember, Hong Kong was one of the seriously affected places by the SARS 17 years ago, when there was an outbreak in southern China. Our hospital, the Prince of Wales Hospital, actually was the first place of outbreak in Hong Kong when the virus remained unknown. And finally, the virus was identified, and the outbreak has led to over 1,700 cases and close to 300 deaths, including a number of healthcare workers. And therefore, most of Hong Kong people are psychologically prepared that one day the virus will come back again. Next slide, please. So going back to the COVID-19, the hospital has initiated a contingency plan in early January 2020, when there were reports of some pneumonia outbreak in Wuhan and confirmed case in Hong Kong in January. So on one hand, on your right-hand side, these are the examples that we have modified our routines, including wearing of the surgical mask in all areas and sometimes upgrade to other PPE if necessary, opening up of some WhatsApp group to communicate and disseminate the information amongst all of our colleagues, triaging all the patients who enter the clinic and the hospital, and also some social distancing barriers, like during the mealtime, we're eating in a glass box with our colleagues. And on the other hand, about the modifications of the patient's management, as you can see on the left side, there are a number of measures we have arranged to minimize the exposure of the patients to infection, and also relocate some of the resources to the hospital for handling the increasing COVID-19 patients. For example, we suspend some surgeries or some endoscopy or some other elective procedures to allow more ICU bed or anesthetists for the COVID-19 patients. Next slide, please. At the same time, the Hong Kong government has also taken a number of public measures and border control to contain the first wave of outbreak in January, which is cases are mainly from China, and the second wave of outbreak in mid-March, which was due to the imported cases of COVID-19 from other countries. Fortunately, as you can see the incidence chart below, the situation has become gradually better since late April and also in early May. Now only we have only occasional imported cases of COVID-19 in Hong Kong. As a result, the city actually is preparing a gradual resumption of normal activity, including the opening of school and resumption of works in office, for example. Next slide, please. Then how about the next slide, please? Then how about the cancer services? Next slide. Next slide, please. So in this slide, I'm showing you one of the figure in the clinic that we have obtained recently. In the lower row, I'm showing you the attendance of the patients at our joint hepatoma clinic, which is a weekly clinic seeing liver cancer patients. The blue line indicates the number of attendance, while the red lines indicate the no-show or canceled appointment. We used to have around 100 attendance prior to the COVID-19 pandemic. When you see the number, you can see initially in January, February, actually there's a high rate of no-show, mainly because the patients are worried about coming to the hospital. But as you can see, in starting from April till May, actually there has been gradual increase in the number of the attendance in the clinic, while the low-show rate number is actually decreasing. And this actually coincides with the upper chart, the decreasing incidence of the COVID-19 in Hong Kong. So basically, all these are showing a sign of a gradual recovery of the clinical service for our cancer patients to previous or normal services. Next slide, please. So what are the considerations when we are resuming our daily normal services? I'm going to share 3 points only. First, we consider still necessity to continue the vigilance measure against the virus. For example, we still, when we open up services, we still continue triaging all the patients by checking their temperature, travel history, and screen for any respiratory symptoms. And if the patient has symptoms or any fever, we need to immediately cohort them and go through the standard operating procedures in the hospital. And also sometimes we recognize that sometimes the travel history of the patients may not be very reliable. So thanks to the government and hospital, in our electronic system, actually we will get alerted if the patient had record of travel in or out of Hong Kong within the 14 days, so that we can correctly collect the travel history. And also surgical mask or corresponding PPE will also be put on if continuously, even after we are recovering from the pandemic. Next slide, please. Next slide. Yes, thank you. In contrast to the radiation oncology side, we do see, actually we are seeing a surge of number of the patients. I think one of the reasons because of a backlog of deferred follow-up, and also we do see some new diagnosis of cancer which have been delayed a bit in diagnosis, which are now coming to our attention. This undoubtedly, together with the vigilance measures, sometimes it can add a lot of pressure and also workload to our staff. We actually have our department have discussed about this issue before when we come up potential strategies, and also in line with our previous speakers, we need to be flexible. For example, we do recognize sometimes the clinic are overrun a lot, and so that we allow some flexible lunch timing for our colleagues. And also we engage more clinical staff, and also we arrange the manpower so that we give more resources to those overrun clinics. And also we engage more non-clinical staff from home office now going back to the hospital for more administrative support or those secretarial support. And also we will coordinate with other specialties like surgeries or our GI colleagues for more quota to clear up those elective procedures like endoscopy or insertion of the portal-cath, etc. for our patients. Next slide, please. So the last point is about apart from the increase in the number, we also encounter patients with more complications to manage. I'm showing you this nicely drawn figure published by Departmental in the Journal of Hepatology. It focuses more on the cirrhotic patients, but I think it also applies to the cancers. There will be second or even third wave of impact of the pandemic after the lockdown period or the physical distancing policies. For example, patients may have more high-risk behaviors, food, smoking during the lockdown period, which will also complicate the cancer management. Also, there may also be some interval progression of cancer where they have limited access to the clinical services during the outbreak. And both of these will definitely affect the management of the cancer. And as oncologists, we need to be prepared to see these and manage them, this problem timely. So next slide, please. So in conclusion, COVID-19 has undoubtedly affected our patients, but most countries and regions should probably have seen the peak already, and now probably also in the recovery phase like Hong Kong. And during planning of resuming the clinical service for them, definitely there's a lot of challenges, and we need to pay attention to these problems, which I've mentioned before. The last slide. Next slide, please. I would like to end my talk by showing these pictures posted by our CHK medical faculty to advocate social distancing to the public in March. I would also like to acknowledge the efforts of all of the healthcare workers. Without your efforts, we could not be able to speak on this topic today, and also because we couldn't speedily resume the services for our patients. Thank you very much. That's the
Thank you. Yes, thank you, Dr. Chan, for your excellent presentation. It's been a great privilege to have you all three sharing with us your experience and your presentation. And now I think it's time for a Q&A session. It's time to listen to the audience. I have some questions that we have received here. Let me go and collect them. Here we are. We have some question for Dr. Pierce. Dr. Pierce, the question says, do you test all patients before starting radiation?
So, no, we do not. And I think in part it's because we have not had enough testing, options to test in the United States. We've had a shortage of testing. We test all inpatients, and most radiation oncology practices in the U.S. do not test for the outpatients. There are a few, such as those that are, some are in the hot spots in New York City. I understand that some of those practices did test everyone. And I understand that the yield rate for those who were asymptomatic was quite low. So in general, we do not test asymptomatic patients. For those patients that we know are COVID-19 positive, in the cases where we could defer treatment, we did and waited until their test came back negative. And for those who could not have the treatment deferred, we treated them at the end of the day on one unit so that we could protect the rest of the patients being treated. And we kind of kept those patients, the COVID-19 patients, sequestered on one unit. But no, we do not test all patients for those who are asymptomatic coming into outpatient units in the U.S.
Here we have another question for you as well, Dr. Pierce. It says, if a patient is COVID positive and you have to give XRT urgently, for example, for core compression, is there a special procedure for linear accelerator and staff precautions?
Yeah, that's a great question. So that's a case where clearly you need to treat that patient immediately. And in many of those cases where you're treating core compression, you can see the spine, you can see those in plain films, and you can do something called simulation on set, where instead of taking the patient necessarily to the simulator and then taking them to the treatment unit, you can often do the planning on the treatment unit. So that minimizes other staff being exposed to that patient. And then again, that would be a type of patient where you could treat them at the end of the day on one unit dedicated for COVID-19 patients. And that's a perfect example of a case where you could treat them with simple planning. Treat them with a field from the front and from the back, or maybe from a single field from the back. So that's a perfect example of not needing complex treatment planning, being able to treat them in a simplistic fashion, but yet giving them adequate care.
Thank you. A question for Dr. Soria. It says the U.S. cancer centers have also reported a significant reduction of hospital census for medical oncology patients. What do you think has happened to these patients?
Thank you for the question, Dr. Rogado. I truly believe here we are in front of a paradox that is an imbalance of perception of risks. I think many cancer patients believe that the risk of getting infected by SARS-CoV-2 by coming to the hospital is higher to the risk related to the progression of their cancer. And they are just hiding. And this is an extraordinary phenomenon that is happening across different cancer centers, across many locations in the world. And is not idiosyncratic to a given cancer center. It's very, very general. And I really think we are losing a communication war here, which is to explain to someone who has an active progressing cancer that the risk of his health being damaged is bigger by that cancer than by a theoretical risk of getting COVID-19 or having a severe form of COVID-19. So we have started an aggressive tweeting policy in Gustave Roussy. We have reached out to charities that have also started that line. And we're seeing a little increase in the number of patients coming. But I think this is a real issue that we need to tackle. And I think ASCO is extremely well positioned to reflect on this paradox.
Maybe we can have also the point of view for Dr. Chan concerning this question as well. concerning the significant reduction of hospital census for medical oncology patients. I don't know if you have the same opinion, if you have experienced the same situation in Hong Kong. Could you please tell us your experience?
Sorry, I could not hear clearly. Could you repeat the question again? Yes, sorry.
Was this: if you have seen a reported significant reduction of hospital census for medical oncology patients, and if this is the case, what do you think has happened to these patients?
In summary, we as I mentioned in my talk, we do see the reduced patient attending either new cases or old cases at our clinic during the COVID-19 era, and we do see now increasing number again. But the details we don't. I think, as I mentioned by Dr. Soria, I think it's a good point for ASCO to collect this data. We don't have so many data about this in Hong Kong yet.
Okay, I have some more questions. Here it says, for example, I think this is good for you all three. Patients who are COVID positive needs to receive chemo. How long do you wait to start or restart treatment? Maybe we can start with Dr. Chan.
This is a good question. I think we don't have a clear answer. We do have sometimes discussion amongst our colleagues and within our team. I think it depends on the aggressiveness of the cancer and the severity of COVID-19 of the patient, and also what type of treatment. I know it's still a controversy, but generally there's some data from China that if the patient receives some anti-cancer treatment, especially those immunosuppressive treatment within 14 days, they're high risk of complication from the COVID-19. So in general, we try to defer it at least 14 days or even longer. But of course, this has to be balanced about some aggressiveness, the aggressiveness of cancer, whether the patient can wait. And also sometimes for patients receiving less immunosuppressive treatment like the TKI or sometimes immunotherapy, there may be a chance where we start earlier. But of course, mind you that those patients with COVID-19 also usually they have some other organ deregulation like liver function and pulmonary problems. All these also contribute to the delay. I don't have a metric figure here, but in general, we try to defer at least 2 to 3 or 4 weeks before we consider resuming the treatment.
Thank you. Dr. Soria, is this what you think, or can we have?
Thank you, Alvaro. I'm very aligned with Dr. Chan's evaluation. I think it depends on the nature of the underlying cancer and how aggressive it is, and mostly what is the clinical features of COVID-19 that the patient presents. If he's asymptomatic, the situation is very different from a symptomatic patient. So if the patient is symptomatic, we will really try to delay and see an improvement in the COVID-19 situation before we start chemotherapy. If the disease is really evolving, we might consider alternatives to lymphopenic cytotoxic chemotherapy, whether through immunotherapy or targeted agents that, in our opinion, are easier to handle in COVID-19 patients.
Thank you very much. I have another question for you from the audience. It says, in the coming months, do you expect an increase in the number of patients related to the delay in secondary prevention studies during the pandemic? Maybe Dr. Soria, you're here, you're listening now, maybe you can address this one.
Well, I'm not totally clear on what the question is trying to state in terms of secondary prevention studies, but what I am sure is that the patients that have disappeared are somewhere, their cancer is not gone, and we're going to have a wave of patients coming back. And my concern is we're going to have a wave of patients with more severe clinical scenarios that are not going to be always easy to handle, that might need, for instance, more surgery, more aggressive chemotherapies. And that is one of our concerns, because as we are modeling going back to normal, we are modeling on the basis of phenotypes of cancers that we are used to handle with. But I was discussing this morning with our hematology colleagues, because as you can imagine, in heme malignancies, the kinetics of tumor growth and proliferation is usually higher than in solid tumors. And they are all pretty surprised over the last 2 weeks in Paris by seeing many patients which are much more clinical, overt, aggressive hematological presentations.
Great. Thank you. I would like to ask also Dr. Pierce about this question as well. If she thinks if we are expecting an increase in the number of patients related to the delay during this pandemic situation. What is your opinion?
Well, I must say, hearing Dr. Soria's comments, I was quite concerned about what the hematologic oncologists are seeing. Our hope is that the delay was not long enough to see a significant increase, but I suspect there will be an increase. And I think it's important to be able to reassure patients that they can return to their healthcare providers, that they can be seen. I think it's important to reassure primary care doctors that if you have patients who have symptoms, we are still a cancer hospital. We can still handle these cancer patients. So I think part of this is going to be reassurance to patients as well as healthcare providers that if there are concerns, that patients come back in and be seen and be screened.
Thank you. I have another question. This could be for Dr. Chan. It says, how has the practice for biomarker testing changed, if you have seen any change at all, and for example, for progressing patients?
Maybe we can discuss. I don't understand these questions completely. Are they referring to biomarkers for cancer or for what was the? I don't understand this question completely. Are they talking about monitoring?
I understand about biomarker testing in terms of diagnosing so you decide what treatment is available for patients in terms of their mutations or their biomarkers. For example, for colorectal or lung cancer, if you have experienced any change in these diagnosis procedures during the pandemic.
Maybe I can partially answer that. We do in our routine practices, we do monitor some biomarkers in some cancers like AFP for HCC or the CEA for the colon cancer or some adenocarcinoma of lungs. And actually during the COVID-19 period, sometimes I can see most of the patients, they usually do not prefer to undergo imaging in the radiology department, probably because of the concern about the risk of COVID-19. In that case, sometimes we do monitor the tumor markers more frequently to see the response of the treatment and monitor any progressive disease. But as we know, we are gradually resuming the normal practices now. I think we don't have too much significant change on the testing of biomarker. But I can notice the next question, which we can discuss later. Sometimes the pressure on the radiology side can be quite a lot. Now we're seeing patients piling up, lining up for the imaging, which the radiology department may not be able to cope with. Yeah.
Thank you. I think we have time for two more questions. I have one for Dr. Pierce. It says, the surge will affect imaging services significantly, to catch up with existing patients, assessment, and work up new patients. Any tips how to manage this new pressure on radiology?
So without a doubt, radiology shut down at the height of the pandemic, and so there are many patients who do wish to come in and be screened. Any tips on how to put pressure on radiology? I think radiology is a very important part of our oncology practice. And it's a very important part of any oncology team. And I think you have to look at this from an institutional perspective and look at the patients and look at where they are and where they're waiting to come in. And I think from an institutional perspective, that is where radiology will be encouraged, if you will, to open up every screening opportunity, to open up the clinic hours, to open up the possibilities for screening, and to be able to very rapidly decrease the backlog. I think to look at a discipline unilaterally is not the way to go. I think you look at the system, you look at the impact for each of the departments and how they have on the system. And from a systematic approach, that's how you manage each of the disciplines for cancer management.
Okay, thank you very much. We have the last question, and I think we can address it for all of you. We can start with Dr. Pierce and then follow with the other speakers. It says, what will be the long-lasting impact on cancer care in your opinion? the new normal highlights?
I think we all are going and have gone through just a terrible time. But we're learning lessons. There are things that we are learning from this. There are things that we can take from this and be smarter, be more efficient, be able to help more patients as we go. One thing that I mentioned in my talk, and I think my colleagues mentioned in theirs, telemedicine, I think, is here to stay. And I think we need to learn how best to incorporate telemedicine in our treatment algorithms. It's not appropriate for everyone. It's not appropriate for every phase of care, but we have to learn where we can use it effectively for patients who live very far away. In radiation oncology, for example, if patients who live very far away, perhaps the initial consult can be done virtually. And then when they come in for their simulation, then you can do the examination. So collectively, you can make it all work and you save them a trip coming in from a long distance. So I think we will be leaner. I think we'll be more efficient. And I hope that we will actually be able to accommodate more patients than we can right now. So my fingers are crossed that we will emerge in a stronger way.
Okay, Dr. Soria, the long-lasting impact from your side?
I'm totally aligned with what Dr. Kerr has stated. I really think telemedicine is here to stay. On top of what she has said, I think we have a massive challenge, which is to explain to the patients when is telemedicine relevant. Because from a patient perspective, the more telemedicine, the better you are, correct? Especially if the COVID-19 risk stays for many, many months. We need to be very clear on when is this logical, when it is a win-win both for the patient and the healthcare professionals, but when it is not in favor of telemedicine, we need to be able to lay it out very, very clearly. And I think that is very important, an important challenge. I think some of the positive elements of this crisis is a much better interaction between administration and healthcare workers. I really hope we can keep that interaction and make it fruitful and sustain in time.
Thank you. Dr. Chan, your time, the long-lasting impact.
I agree with Dr. Pierce and Dr. Soria's thoughts. In addition, I'm more pessimistic. I think I'm worried that such kind of pandemic or some emergent problem will come back again, even recover from this episode. I think, as Dr. Pierce mentioned, it's a good time we need to sit down and we think about our clinical services. In case there's still another lockdown again, in case there's an outbreak again, I think we should do much better. We should have some SOP, some standard protocols to define the role of each others in case we really need to work at office or with a limited hours. And also telemedicine, as mentioned, is something that we also should think about it. Do we still need hundreds of patients come back to the clinics and do all the tests together? I think this is something that we need to, the whole oncology world should think about in the future.
All right, thank you very much. I would like to thank all these, our three distinguished speakers, Dr. Pierce, Dr. Soria, and Dr. Chan, for accepting this invitation to participate in this global webinar series. Thank you very much for your presentation, for your superb discussion, and for sharing your experience with all of us. Now I hand over to Doug Pyle, Vice President, ASCO International Affairs, for the final wrap-up and conclusions.
Well, thank you, Alvaro. You really said it all. I just wanted to say thank you again to Dr. Pierce, Dr. Soria, Dr. Chan, for your excellent talks, your insights, helping all of us to respond to this pandemic and learn from each other. Incredibly helpful, and thank you for your time. Alvaro, thank you again for being such an excellent moderator and fielding the questions. And thanks to all of you for joining us from around the world and all of your excellent questions and your participation. As a reminder, the presentations and answers to questions about COVID-19 presented on this webinar today provided by the American Society of Clinical Oncology for voluntary informational use by providers. The information is not intended to substitute for independent professional judgment of the treating provider in the context of treating an individual patient or developing practice policies and procedures. This concludes our first webinar series. Look for announcements from ASCO on future webinar series on the COVID-19 pandemic subject. As always, check the ASCO web pages for additional COVID-19 resources. These are updated routinely. And thank you again for participating. And please, everyone, stay safe and our very best to all of you. Thank you.